Good afternoon and welcome to the afternoon of the first day of our two-day LGA ADPH conference, annual public health conference 2021, Rising to the Challenge. So this is our second webinar of the four that cover the 2 days. And we really are delighted to have 1,000 registered attendees across the whole conference. We've had a great session this morning. There was some lively Q&A on the conference itself, as well as good lively tweeting. So please do feel free to use the hashtag LGA Public Health 21, and you can also get a flavor if you weren't able to get to the first webinar. You'll have a flavor of the conversation then. But what we had was our Chief Medical Officer, Professor Chris Whitty, opening the conference with us. Or for us, with an inspiring address and Q&A session, a lot of interaction with all the delegates, the attendees, reflecting on the learning over the past year, reflecting on the huge impact of health inequalities in this country, but also looking forward to 2021 and our ambitions as we move forward. With the second part of the morning, we had a panel discussion on public opinion and public health, where we explored how people and communities have engaged with public health messages through COVID and what the learning has been over the past year. So this afternoon, what we're going to do is look at the challenge around health inequalities and recovery. And we've got an excellent panel of speakers who are all working to ensure that health inequalities are at the center of the recovery efforts. We're going to have the opportunity to explore where community-led approaches are having an impact in reducing health inequalities, and discuss the immediate and long-term priorities that can help us mitigate the impact of COVID-19 in our local communities. I really encourage you to submit questions through the Q&A function. So what we'll do is we'll have each speaker, I'll introduce them at the start of their talk. If you feel free to use the Q&A function, which is live as they're talking, after the fifth speaker, we'll then have the panel together and respond to questions that have come in during their talk. So I'm delighted to be joined on the panel to explore the theme of health inequalities and recovery by five esteemed guests. And we'll kick off first with Professor Kevin Fenton, who's Regional Director in London, Public Health England. Kevin, over to you.
Thank you, Janelle, and good afternoon, everyone. Janelle, I hope you can see my slides.
Yes.
Let me begin by just saying thank you so much for the invitation to speak this afternoon to the conference. This is truly an important time for us, and I'd like to begin by thanking everyone and just acknowledging the tremendous work and partnership that we've done together over the past year to get through what has been an unprecedented and very challenging time. I think all of us have been affected by this pandemic in so many ways, but I am confident that we will emerge from this stronger, far more integrated, far more collaborative than we could ever have imagined. So today I've been asked to reflect on our journey with health equity and the COVID response and the lessons that we have acquired over the past year. And I've also been asked to reflect on our own journey in London and what we're doing and learning differently in response to the pandemic, leaving a foundation for addressing health inequalities in our city. So I'll begin by just quickly reflecting on where we began nearly a year ago when we were asked by the Chief Medical Officer and then the Secretary of State for Health to do a rapid investigation into the risks and outcomes, disparities in risks and outcomes for COVID. We did a mixed methodology work at that time, looking both at the epidemiological data, routine health and surveillance data available, as well as a stakeholder engagement exercise review of the literature involving more than 4,000 people over a 6-week period. Now, many of you will remember the key findings from the report. We were able to, for the first time and systematically, really describe the differential patterns of disease by age, geography, the impact of deprivation, and of course, the variations across ethnic groups. And in the key recommendations which arose from this work, we really highlighted what I think have become three of the most emblematic phrases to really characterize this pandemic's impact on communities. The first was that the inequalities they existed before the pandemic, but the pandemic has certainly worsened these and exacerbated these inequalities and made them far more apparent. Second, the reports really underscored the importance of the social, the structural, the cultural, and the behavioral factors which are driving and underpinning transmission within communities across the country, in addition to a number of the clinical risk factors which were identified at that time. And finally, the report captured the hearts and voices of our communities across the country, both dealing with the trauma of going through the first wave of the pandemic, but looking forward and asking that communities are a core part of the actions, the recommendations, and the changes which are made moving forward. Now, the reports had 7 key recommendations which were based upon the review, the data, and the stakeholder engagement. These covered a wide range of topics, but were largely geared towards actions that could be implemented in the short and medium term to help to mitigate the impact of a second wave, but also to ensure we were building the foundation for changing the way we engage communities and tackle inequalities as part of the pandemic. So we covered both data, research, culturally competent interventions, and actions that all partners, system partners, should be putting in place to address the issue. Now, over the year, we have continued to see the impact of the pandemic on a variety of communities across our country. And here I'm simply highlighting some of the changes and challenges that we observed across ethnic groups over the past year. Throughout the course of the pandemic, we've seen a disproportionate burden on our communities, minority communities, with those of South Asian backgrounds, especially Pakistani and Bangladeshi communities, bearing a disproportionate burden in addition to our Black, British, African and Caribbean communities. And as the epidemic has evolved, affecting different geographical areas of the country, we've seen these repeated patterns of risk continuing to play out. But there are other domains of inequalities that we have observed, and we've also, over the past year, learned more about some of the structural drivers of the pandemic. And here I'm highlighting just a few, because I know in your own jurisdictions and in your own work, you now have a clear understanding of the factors driving enduring transmission and risk. So for example, we now appreciate and understand the importance of household size and composition, and the fact that the largest households are 3 times more likely to get COVID than the smallest households in the country. And they're also 7.5 times more likely to die from it. We've also seen the differential impact of patterns of multi-generational housing, as well as patterns of overcrowding in households, and how that has an impact on influencing COVID rates. We also have a better understanding now of occupation and how occupations can increase probability of coming into contact with people who are infected, but also by virtue of simply being in contact with more members of the public, how that can increase your risk of acquisition and transmission of the infection. And we also understand that Black, Asian, and minority ethnic communities occupy higher proportions of some of the most highest risk occupations within our country. And that lesson from wave 1 meant that as we went into wave 2 and beyond, we've been doing far more work with our workplaces and occupations. We also now understand that interesting and challenging intersection between ethnicity, deprivation, and risk of acquiring and transmitting infection. With increasing deprivation, as highlighted on the left-hand side of the chart, we know that we see an increasing proportion of minority communities being affected. And here you can see particularly the Pakistani communities being disproportionately affected. But we also understand that with each level of deprivation on the right-hand side of this graph, with increasing proportion of the population, in this case of South Asian communities, we do see increasing risk of increased disease incidence. Finally, we know that these inequalities have tracked throughout the pandemic over the past year, We initially described it for increases and differentials in testing and diagnosis. But as we rolled out our contact tracing program, and as we've rolled out self-isolation programs, and most recently with our vaccination programs, we have continued to see variations across groups, either by ethnicity, age, or deprivation. And again, an example here of the differentials we're now observing in vaccine hesitancy across various ethnic groups, and the material impact that this is having on the uptake and coverage of our vaccines across the country. And these differences will have a severe impact on both ongoing transmission within the community, as well as potentially areas for enduring transmission as we emerge from the second wave and prepare for the summer. So very briefly, to reflect a little bit then in closing on London, we have had a pretty severe pandemic experience with the pandemic in the city, with more than 700,000 Londoners being diagnosed with COVID, and unfortunately having lost more than 15,000 of our fellow citizens. We've seen a disproportionate burden of disease across the city, with boroughs, especially in the outer ring of the city, having higher mortality rates than those in the centre. Given our experience over the past year and the work that we have been doing on inequalities, London partners have pulled together to ensure that as we view recovery in the city, we're doing so with the lens of equity firmly embedded in everything we do. The Mayor of London, working with our local government partners, have now identified a grand challenge for London with 9 missions for recovery in the city. Those 9 missions meant to restore confidence in the city and minimize the impact of the epidemic on London's communities. They cover things from health and well-being, whether mental health, as well as healthy food and healthy weight, straight through to sustainability with a Green New Deal, a better deal for young people, digital access for all, and of course, building strong communities and work for all. All of these missions involve partnerships between statutory agencies, the Greater London Authority and London councils and our partners. And key cross-cutting principles are highlighted here, ensuring that inequalities are placed in everything we do, collaborating with diverse communities, leveraging the impact of digital technology and data, and focusing on sustainability, health and well-being, and affordability of our interventions. Now, in addition to our grand challenge as a city and these 9 missions, our system partners are working together to ensure that we keep a laser focus on key outcomes, tackling those social and structural drivers, including inequalities, unemployment, and ensuring that our young people can flourish. Finally, we are working again as system partners on key aspects of driving forward the results from the beyond the data recommendations, building system capacity to understand inequalities and respond to those inequalities across all system partners, and working collaboratively as a system to address key recommendations from PHE, from the NHS Phase 3 letter, as well as recommendations from our ADPH partners in the city. The policy response to inequalities have been strengthened by the launch of a health in all policies approach, leveraging the assets in the GLA, but also working closely with our London councils. And we're now embarking upon the refresh of the London Health Inequalities strategy. We're using data differently across the city to both characterize inequalities, leveraging information from system partners, and developing core inequalities data sets for monitoring in the city. We're focusing on our workforce, ensuring that equality, diversity, and inclusion is a part of everything we do, but also ensuring that workforce well-being is a core part of protecting and supporting our minority staff, those from disadvantaged backgrounds, and looking at the role of our organizations as anchor institutions. We are changing the way we engage with our communities in terms of better mutual aid, better engagement, and the work that we're doing now on vaccine hesitancy and engagement, I believe, is setting a new foundation for community participatory programs, both in public health and policy. And finally, strengthening the way we look at communication and engagement as part of our work. So Janelle, I'm going to pause here. This is a story of a year of change, a year of challenge, but I believe that together we have demonstrated that we can rise to those challenges and we can have a lasting and enduring impact on the way we both understand inequalities and the way we respond to them. Thank you.
Thanks, Kevin. That was brilliant. Great today to show the entire year that we've experienced and that you've experienced in London, and to see that kind of progression through the year. Thanks for that. So we'll go straight on to Dr. Jo Bibi, who's Director of Health at the Health Foundation. Jo, over to you.
Great, thank you, Janelle. So I'm going to share my screen as well. So hopefully most of the people here are familiar with the work of the Health Foundation, but just a very short sort of overview. We fund research, policy and improvement work to improve health and healthcare, and have a number of programs that are aimed at reducing inequalities and addressing wider determinants of health, some of which directed at councils and public health leaders, particularly our Shaping Places for Healthy Lives programme that we do jointly with the LGA, and our New Economies for Healthy Lives programme. And we also do a range of in-house analysis with a lot of long reads and data on the relationship between health and wider determinants. So that's a bit about us. But reflecting on the theme of the conference, Rising to the Challenge, I was kind of thinking about, which challenge to focus on. Clearly, the community's been through a very challenging year, and there's more to come. But one of the questions that I've been considering is, how can we build public support for the action needed to reduce inequalities in health? Because I think this is fundamental to getting the change we want to see. And in doing that, there's three questions I come back to. One is, do people know? Do they know the extent of inequalities in health? Second, do they care? And thirdly, do they buy into the strategies? So on the question of, do people know? Now, clearly, those of us who live and breathe this, and we're often looking at charts like this one, looking at the difference in life expectancy, healthy life expectancy, it's all eminently clear to us, the issue of health inequalities in our society. But what I have observed when I talk to people outside the public health community, and both people who are expert in some field of their own, as well as people who are potentially more lay members of the public, is that actually the extent of the health inequalities that exist often isn't that familiar to people, and particularly the inequality in healthy life expectancy. So I think this is something we need to hold on to and bear in mind, that perhaps people aren't really fully aware of this. Now, on this question of, do people care, there was a fascinating report published last month by Bobby Duffy and colleagues at King's College London. It's part of the Deaton review that the IFS are doing on inequality. And as you see the title, Unequal Britain, Attitudes to Inequalities After COVID-19. Now, it looks at a whole range of inequalities, but the question that really I was drawn to was the question about which three or four of the following in areas of inequality do you think are most serious? And the responses that came out was, at the top, the sort of area of greatest concern was the inequality between more and less deprived areas of UK, then income and wealth, then between racial groups. But the one that we're concerned about, health and inequalities in health and life expectancy, actually comes surprisingly low down for people like us, who are concerned with this list. And this really got me thinking. And in some ways you could say, well, we all know that actually deprivation and income and wealth are the big drivers of health and life expectancy inequality. So does it actually matter? But if the conversation we want to have with the public is about the need for action on wider determinants of health, and they don't understand those connections, maybe they're not really understanding why we're prioritizing the things that we're talking about. Now, this work that was done by King's was based on it was sort of over 2,000 poll with YouGov of a cross-section of the British public. But the Health Foundation, as part of our COVID impact inquiry, we're also doing some deliberative work with the public. And this is actually, we've been running a series of workshops across the UK with cross-sections of people to really explore inequalities, health inequalities, and the impact of COVID. And I think what this has sort of started to show is that there's a bit more of a kind of nuanced position in terms of the public understanding of inequalities. And we've been working with Kantar, and they have 4 category segments of the public. There's a segment they call the activists that we've been working with, and these are people who see the issue of health inequalities and see the possibility for societal change. So kind of absolutely the people, I'm sure we all fall into that category. There's another group they call recognisers. They recognise the issue, but they really don't know what can be done about it. The third they call disengaged. They see the issue, but often they just think, well, that's life. This is just kind of what happens in our society. And then the fourth group are the skeptics, who have generally lower awareness of health inequalities, and in so much as they do engage, they're kind of more likely to look at individual level solutions. And just to show you how these segments break down across the population, reasonably even split, obviously slightly more in the skeptics, but I think this starts to sort of perhaps explain, those of us who are activists, we are in the minority here. And there's something about how do we actually start to communicate in a way to the recognisers, to the disengaged, to show that actually this isn't inevitable, that things can be done and that change is possible. So one of the other things then is, do people buy into the strategies that are needed for the change we want to see? So again, going back to the Unequal Britain report, people were asked about the factors they associated with people's health and life expectancy. And this list here, you can see at the top, people associate access to good quality health and medical care. Then lifestyle choices, social care. I think interesting how we're brought up as children is fourth. But the kinds of things that we would be talking about in terms of inequalities, the housing, the employment we do, the education people have, are all lower down in people's understanding as to what's contributing to people's health and life expectancy. So I think, again, kind of reinforcing the need for better explanation and communication on this. Now, in the deliberative work that we're doing, one of the things we are able to do is really explore with people their understanding of what's driving people's health, and we do give them some information and evidence to reflect on. And I think one of the things that's really struck me sitting in on these conversations is that when people are given the evidence around wider determinants of health, actually, it becomes very intuitive. People really do get it. Some of the groups I've been in see education and skills as absolute, that sort of foundational things that kind of really drives other aspects of your life. Other people see work, employment and income as foundational, but there's a real sort of intuitive engagement. However, not quite so positively, is that then at the end, when we've said to people, what would you like to see the government doing to address health inequalities? Generally the response is, more funding for the NHS. So I think this really does start to surface the fact that there is this kind of disconnect in the public understanding between both the awareness of inequalities, but kind of what needs to be done to address them. So I think one of the challenges we need to think about for the next year is, how do we increase our understanding of the public's understanding of health inequalities? Because I think without that, there's a risk that we're kind of like ships in the night. We're not really communicating. We need to find better ways to communicate about health inequalities that start from that understanding. And so some of the work we're doing at the Health Foundation is, we have our COVID impact inquiry. We'll be writing up the findings from our deliberative work in that and publishing in the summer. And another piece of work we've had underway for some time is with the Frameworks Institute, which is an organisation that looks at how you frame complex social problems in a way that the public can engage in. So these are my reflections on some of the challenges ahead, and look forward to a chance to discuss them. So thank you.
Thanks very much, Joe. Fascinating. I love that. Increase our understanding of the public's understanding. It's a great line. Thanks very much. I'm sure we'll come back to that in Q&A. Let's move on then to Alice Wiseman, who's Director of Public Health in Gateshead. Alice.
Thank you, Janelle. So as Janelle said, I'm Alice Wiseman, I'm Director of Public Health for Gateshead, and I'll start with the front cover for my annual report for this year. And I think COVID-19 has highlighted and exacerbated, in my view, our shameful position on the growing gulf between the haves and the have-nots across England. This year has been hard for everyone, but I want you to try and imagine what it would be like living in a small property with little or no outdoor space, worried about heating your home, feeding your kids, or providing access to the necessary IT so your children don't fall behind at school. And then add to that the fear of bringing COVID home to your family, to your mum who provides the childcare, or risk losing your job. Imagine being furloughed on 80% of the national living wage with no chance of overtime to top up your income. Imagine being told that your child should isolate as a close contact, but that means you can't go to work and therefore you won't get paid, or worse still, you might lose your job. COVID has exacerbated and shone an even brighter spotlight on the unacceptable inequalities that we have in the UK today. But what have we learned from this? So this is lessons from our teacher called COVID. Next slide, please. I know that we all know this already, but many of the factors that have created and exacerbated inequalities during COVID have not only been driven by physical health independently. Inequalities are driven by that interaction between the wider determinants of health, the psychosocial impact of those experiences, health harming behaviours that many times are adopted in an attempt to alleviate the psychosocial impact, and culminating in the physiological impact of those interactions together. The things that create the context where inequality thrives, housing, employment and education, are many of the same things which prevented people from being able to protect their families and their communities during COVID. Next slide, please. Evidence has identified the potential pathways that link deprivation to higher COVID-19 infection rates, cases, case severity and deaths. Exposure as a result of inequalities in working conditions. Lower paid workers, particularly in the service sector, were much more likely to be key workers and therefore required to work during lockdown, also much more likely to rely on public transport. And we know that there's a clear social gradient in the ability to work from home. Transmission, inequalities in housing conditions are also likely to have contributed to inequalities in COVID-19. Deprived neighbourhoods are more likely to contain houses of multiple occupation, lack outdoor space, as well as experience high population densities, which may have also increased transmission rates, as well as making isolation much more difficult. Vulnerability due to a higher burden of pre-existing health conditions that increase the severity and mortality risk of COVID-19. And we know that these comorbidities arise as a result of the inequalities in the social determinants of health. Finally, susceptibility due to an immune system weakened by long-term exposure to adverse living and environmental conditions. The social determinants of health also work to make people from more deprived communities more vulnerable to infection from COVID-19, even when they have no underlying health conditions. Next slide, please. Thankfully, evidence has shown us that children and young people have the lowest clinical risk from COVID. Nevertheless, they have experienced a year of disruption at arguably the most critical time of life for development. Many children have missed months of education. However, the impact of this has been different, and there have been marked inequalities in learning hours, digital access to resources, and completion of homework. Even before COVID, around 30% of children in the UK were living in poverty. Poverty is an enormous source of stress for families, and we know that when parents are overwhelmed by stress, they can struggle to meet the basic emotional, physical needs of their children. This in turn can adversely affect the physical, emotional, and social development, impacting on the child's brain and immune system, leading to susceptibility in mental health problems and chronic disease in later life. There are significant concerns about the overall mental health and well-being of children and young people resulting from the increased family stress, reduced access to early intervention and support services, and decrease in social interaction with others during the pandemic. For some, again, this will have been exacerbated as they have experienced the repeated stress of abuse, neglect, parents struggling with mental health or substance abuse, problems potentially being stored up for a generation to come. Next slide, please. From the perspective of infectious disease, there is little point in having a small us. Our secret weapon in the fight against COVID has been our communities up and down the country. We've observed in a very tangible way the art and science of promoting health through the organised efforts of society. COVID gave us a collective goal, a greater sense of us for everyone, at least initially. Even if an individual's ultimate goal was to protect the small us, me and my family, it was understood that we could only do this by working together. Next slide, please. Our teacher called COVID. Lesson 1 from our teacher called COVID. We can improve and protect the public's health if we're able to find and agree on a collective goal that we want to achieve. The shared cooperation was palpable during the first wave. We all remember the doorstep clapping, the thank you rainbows in windows, and the local community groups stepping up to help each other. We housed the homeless, we fed the hungry, we protected business, and we provided additional income for those who had the least, because we all agreed it was the right thing to do. Personally, I was blown away by the community action during this phase. United against a common enemy, people came together, unaided, independent, and unfettered by process and bureaucracy. And I think this has resulted in a change in community leadership as people reconnected and engaged in social action within their own communities. Lesson 2 from our teacher called COVID. Harness the power of social action in communities. And let's not underestimate the impact on health and well-being of being locally connected as an end in itself. On reflection, I do wonder why it took a crisis to push us as a society to do the right thing. Was it just because their us affected our us? Or did we suddenly see the needs of others around us in a very different way? There is so much evidence that inequalities are bad for us all, regardless of your position and no matter how small your us is. Countries which have the greatest level of inequality are also the countries where crime, and particularly violent crime, is higher, child well-being is lower, and community cohesion is minimal. Rather than recognise need and help each other, we fight each other to meet our own needs. We've definitely seen this in the UK, a rise in violent crime parallel to a growth in inequality. Lesson 3 from our teacher called COVID. If we really believe that inequality is unacceptable, then we must create a narrative that engages people across the whole spectrum of us. We need to get clearer in our mission and the benefit that it will bring for all. Our entire strategy for COVID is built on the actions of citizens all working together in harmony. We needed people to get tested, engage with contact tracing, and then isolate to prevent the onward spread. And this sounds really easy, but we can only secure engagement in those actions if we understand the challenges that people face in doing so. In my opinion, this is the bit of the jigsaw puzzle that was largely neglected at the start. And this is what we must now strengthen. The logistics of scaling up a national testing and tracing system is tangible and exciting, but it falls at the final hurdle if we don't understand how people experience these measures and how they interact with them. Lesson 4 from our teacher called COVID. Work with communities to hear and understand the things that matter to them. As a director of public health and public health teams, local government across the country, we've experienced how it feels for people to be making well-intentioned decisions above our heads and imposing them down with little regard for how they actually land in our place. I'm really sorry if that's hard for anyone to hear, but that is the truth. How many times over the past year have you felt frustrated by the fact that no one seems to understand the nuances that make your place different? No one seems to be hearing why something won't work, or indeed isn't working like it was intended. Infuriating, yes. Avoidable, yes. Disempowering, absolutely yes. But I'm now asking myself, how many times have I actually done that? imposed a well-intentioned initiative or a solution into a community with little regard to the context in that place. For example, healthy eating advice with communities who are struggling to put food on the table at all. So lesson 5 from our teacher called COVID. Engage communities in the solutions, enabling people to maximize capability and have control of their lives, as we know that this is part of the solution. Next slide. So finally, if COVID has taught me nothing else, it certainly taught me what's important in life. It's not fast cars, expensive clothes and luxury goods. They're all nice, but on their own, they're meaningless. I've missed human contact. I've missed my own friendships. I've missed my colleagues in the office, my friend popping in for a cuppa, meeting my mum for dinner and seeing my baby niece take her first steps. This is what I've missed. So finally, lesson 6 from our teacher called COVID. As we look back, both now and in the future, we must reflect, not only on the things that we have done really well, but critically the things we could have done better if we'd had a more equal world. I don't want to see people in my community struggling. One of Obama's chief of staff famously said, "You never want a serious crisis to go to waste. It's an opportunity to do things that you think you could not do before." So I want to believe that we now have a real opportunity based on the shared learning from our teacher called COVID to really come together in this collective space to tackle inequalities. So I'll just finish by asking again, how big is your us? Thank you.
Thanks, Alice. That's a brilliant, challenging input from your experience as a Director of Public Health. Very honest. I hope you also are missing the social contact from a face-to-face conference. So maybe next year, there's something about being face-to-face, isn't there? And just having that social connection to people, physical social connection. Thanks, Alice. So we'll move on then to the last 2 speakers. If I can ask Jim Mcmanus, Professor Jim Mcmanus, who's also Vice President of the Association of Directors of Public Health and a Director of Public Health in Hertfordshire County Council. Jim, over to you.
Thank you. Can you see my slides okay?
Yeah, we can see you and your slides.
Wonderful. Well, sorry that you can see me, but there we are, perfect face for radio. We've heard some very eloquent speakers remind us of the enduring nature of inequalities and the fact that during this pandemic, they have made matters much worse and we really need to address them. And Alice has shared with us 5 lessons particularly. I want to kind of look at what lenses we might have for local leadership in response to this. And I want to suggest to you that there are 3 lenses going forward. And those lenses are tried and tested in public health. And one of the problems with the pandemic is that an awful lot of people have invented science with no science behind it. And everyone's a scientist and an epidemiologist. And if there were as many people claiming to be pilots as there were epidemiologists, there would be thousands of people dying in flight accidents every hour. I want to suggest to you that those 3 lenses are systems lenses, syndemic lenses, and determinants. And we've got them in our toolbox if we want to use them. And actually, I won't dwell on this, but they are part of the kind of leadership toolkit of local public health. And I use here the Health Foundation's leadership model developed by with Ashridge, but I'm not going to dwell on that. And that makes me question terms like enduring transmission. My worry with phrases like enduring transmission is that while it may help us respond, and it may be a useful shorthand term for what is a growing phenomenon, it actually masks the response or risks oversimplifying something which is not enduring transmission. It's multiple infection dynamics which are riven and caused by inequalities and determinants. And if we are not careful, terms like enduring transmission can stigmatize the very communities that are worst affected by them. Inequalities are at the root of propagated multiple epidemics of disease. If we know nothing from HIV, we know nothing. about that. And good epidemiology should understand and complexify what we're dealing with, not deliver linear thinking where that linear thinking may oversimplify. Some more questions there about enduring transmission for you to ponder at your leisure. And the ADPH policy paper, the third of our policy papers on COVID, talks about how we operate safely in an environment where the disease is not immediately vaccine eradicable, where inequalities will persist and long-term impacts will persist. And we call for building back fairer. And that means we need to complexify the impacts of COVID in the way I think that Alice and Kevin and Joe have done. The dimensions of public communication, the dimensions of its impact on different communities, and the move away from linear thinking. And last week, we did a day of self-isolation support in Hertfordshire and knocked on 1,000 doors. And 89% of people were at home self-isolating. Unsurprisingly, 528 people needed offers of support, and most of those people were the people who found difficulties in self-isolating. There were very few people, fewer than 2%, who wouldn't self-isolate or didn't want to. Most people either could or just couldn't and needed help. And those are the dynamics that we need to do some significant work on. And actually looking through the idea of syndemics and systems and determinants lenses is far more valuable for us. So we have these tried and tested tools. I'm not going to talk great length about determinants, but Dettles in 1990 talked about the layers of determinants from biological to social, neatly illustrated, I think, by Kevin and by Alice. And I think once we move on from there, how we look at whether these are tractable needs to be through both a systems lens and a syndemics lens. Well, why a systems lens? Because we know actually that we don't live as isolated, atomized individuals. There are multiple things that impact on our health, from the air we breathe to the services we can access. And so we need to take a systems approach. And if the work on obesity has proved anything, it has proved that actually the one single thing to understand about healthy weight is that there is no one single thing to do about it. There are multiple and many. So we need to become adept at changing and influencing systems. And I'm not going to talk through this, but the work of Donella Meadows is a useful reminder here. But it also reminds us about a level of humility, that we have to work with that line of team of teams. No one person or system has the answer. It's certainly not the NHS, wonderful organisation though it may be, but we need each other in order to actually address the systems approaches of inequalities going forward. The next lens, I think, is a syndemic lens. And if you haven't read Meryl Singer's books or any papers about it on syndemics, I commend them to you. Because actually, as we know, if we know anything about HIV or TB or any other epidemic, it doesn't come by itself. It brings with it stigma, poverty, long-term mental health problems, economic problems, lack of access to care for other difficulties. And that is exactly what we're seeing. How will we deal with that in a way that doesn't just end up putting more money into NHS services when actually the services isn't the answer? So we need a syndemic lens to look at how we recover and how long it will take us. We will have thousands of people with complicated grief. The answer for that is not antidepressants. It is helping people to work through their grief and resolve and rebuild their lives. Not treatment. Recovery and response through a syndemic lens has to be our priority. And if Kevin's presentation did anything in this report, it showed us eloquently just how much the impact on Black, Asian and minority ethnic populations is syndemic, systemic, and actually intimately tied in with inequalities and determinants. And so must the response be. And you could take this for almost anything, young people's mental health, but we have a lesson here that gives us an opportunity to reset how we do health inequalities for the next 10 years, if we are going to do it. This graph is one that I have on my desk daily, and it actually reminds me that there are multiple and syndemic impacts, from structural discrimination in getting access to vaccines, for example, for gypsies and travellers, right through at the other end to the fact that people's jobs may mean they are far more exposed to COVID than those of us who can work at home because they have to use public transport, for example. So as we go forward, I want to suggest that there are three big phases of work for us around which we can use these three lenses. And this is the root of our plan in Hertfordshire for health inequalities and for our public health strategy. The first, that we exit the pandemic phase and manage COVID as part of an ongoing health protection approach. Health protection was always about inequalities. The people who experience the worst environmental inequalities are the people who are the poorest. So we have to exit and be ready for that on an ongoing basis. The second is we have to begin to recover. And that means we need to use analytics and intelligence and the syndemic lens and every piece of insight we can get and work with our partners. I can't do my job in Hertfordshire without our district and borough councils, our environmental health officers, social care, the voluntary sector, and many other, and indeed business. So it genuinely has to be a system approach. And that applies to build back fairer. We can't do that unless we understand the determinants, our population, and actually embed these responses. And it is not about, I would argue, funding the NHS. The NHS is one part of this. And that means we need a dramatic reset of the language around population health. It is right to focus on inequalities with NHS systems, but it is surely also absolutely salient for us to do our part outside NHS systems to work together. And so locally, we've actually been working with businesses. We've done quite a considerable amount of work on supporting businesses, especially in psychological well-being, with our growth hub and with our behaviour change unit. We've actually been looking at how we look at the quality of place to promote better and fairer access to means of transport. And identifying priorities for employment going forward are going to be crucial, as well as educational outcomes. I won't dwell on this, but our prevention strategy, which we passed just before COVID hit, actually talks about how we pursue opportunities to really transform the way we work into giving people better, healthier lives. Now that's ambitious, but I do think it is right to be ambitious. The next 2 years that I want to focus on is how we use these lenses to go forward to do that. So in conclusion, for me, I've had a rallying call today from Chris Whitty, a rallying call from Alice, a stark reminder from Kevin of the impact and the reason why we're in this business, and a real knotty, thorny set of problems elucidated by Joe in relation to where we go next and how we work with people to understand the complexity. The only way I can think of getting through that is to use these lenses, determinants, syndemics, and systems. That also means that we need the leadership of local government as never before, and the leadership of the local members. Which is why I think it is very fitting that we have an elected member summing up this session. So I'll stop there if I may.
Thanks, Jim. That's great. And you've done a brilliant sum up and intro to our elected member, Councillor Paulette Hamilton, Vice Chair, LGA Community Wellbeing Board, and Cabinet Member for Health and Social Care in Birmingham City Council. So if we can move on to Paulette, who's our last speaker, who, as Jim has said, will provide that real local members perspective, and then we'll go to the panel. So over to you, Councillor Hamilton.
Good afternoon, everybody. I was delighted to be invited here this afternoon to speak. I am not one of the eminent speakers on the panel, but I know my community. I was born in the community that I'm now a councillor. I grew up in that community. I did everything that local people do in that community. So when COVID hit, I wasn't surprised at the reaction of the community that I served, but let me just go through and do things in order. The crisis that happened last year really marked our streets and communities across Birmingham, but also across the country. Families lost loved ones, our businesses were suffering, we were losing jobs in the city, we were a very young city, so we really saw the financial implications of COVID really quickly. The growing health inequalities and the poorer communities was incredible because many people in our community last year didn't actually believe that they had health inequalities. The mental health issues within the community was stark from early on. As a city, Birmingham is ranked 7th in the most deprived community of the country. We speak over 90 languages. In a ward such as the ward I represent in Holyhead, we're 84% ethnic minority. So it is a super diverse ward. And also 46% of our citizens are actually under the age of 30. We have a city of 1.2 million people. And we also have, believe it or not, lots of parks and green spaces, but many people don't actually use them. And last year was testimony that people just weren't aware of what they could use. We as a local authority last year, we supported our hospitals and care homes. Also, as many authorities did, we did the usual. We delivered the food parcels. We made sure the safe and well checks were done. We also had the saga of PPE, and we had to ensure that we did what we needed to do in that area to sort that out. But the big issue came in April that I want to concentrate this afternoon. We had within our community around the 11th of April last year, there was, those of you that understand, something called the Eureka dying call. The community just exploded, but it was fear. It's a fear that I have never, ever seen before. It was palpable. You could feel it, you could taste it. You had people in the community refusing to go into hospitals. You had people in the community actually being driven to the hospital and refusing to go through the doors of the hospital. It was terrible. So we decided to call an extraordinary health and wellbeing board. Now, we couldn't just call the board, and remember, I'm talking about this as the person that led on the political front, but we needed all the other partners on board. The public health director and his team were phenomenal, and we also had so much support from the NHS. So we had to promote this. What we found was that that's why I hate the term hard to reach communities, because if you find ways to access your community, they will tell you what the problem is. And so in 1 week, we were able to call a health and wellbeing board meeting. What we said to our communities, what we asked them was, the question was, what are your fears? What are the issues? What do you not understand about COVID? We were overwhelmed. We had over 600 questions from over 200 people. Now, the public health director at the time made a promise that every single question would be answered, and that is exactly what we did. We answered all the questions, we grouped the questions the way Janelle has said she'll do today. We answered all the questions. Some we couldn't do at the meeting, but we made sure that everybody had an answer to their question. I'm not saying that it was the be all and end all, but the community felt they were being heard. And from that, what it really highlighted was the links that we could then see between inequality, between the issues with race, class, gender, disability, and age. We really started to see it early on, what was going on the ground. The inequalities were absolutely exacerbated by the fact that education had stopped suddenly. We had lots of people living in high-rise flats, the health inequalities that were out there, the fact that many of our low-paid workers, if they didn't lose their job, they knew nothing about being at home, furloughing, or working from home, because that didn't exist. We had large numbers of our children and adults, they had no IT support, they were not actually, they didn't have the structures in place to be able to access what they needed to access to continue learning or working. But what we saw most of all was the issues around death. When people started to pass away, in the African Caribbean community and many of the Asian communities, they have rituals, and these rituals were not then being carried out. So many of our local communities were starting from early on, we started to see the issues developing around anxiety, mental health type issues, because they weren't able to grieve in the way that they needed to grieve. But as a city, we knew we needed to respond. We did lots of letters to the government. I got to know Kevin really well at this point because of the report he was doing. The public health director and the leader worked really hard, and the whole council. But what was really interesting at that time was the work we did to actually take on board community champions. These were local people talking to local people about the issues, and to date we now have 782 of them. We also did some work, we started some work with Lewisham, because we found as a city some of the issues around the BAME community, African Caribbean community. They had 5 times more chances of dying at childbirth than any other group. So the issues were horrendous. Then we had the issue of vaccine hesitancy. We know this was an NHS issue, but it became a local issue. I keep saying we know our communities. Local government absolutely knows their community. So what we had to do at this point was join with the NHS and started doing series of webinars. We went out there and did radio interviews, we did talks, anything we could do one-to-ones to encourage people to become confident in taking the vaccine. We then, as a community, we saw the impact of social distancing. I'm not going to go on because time is short, but the impact of social distancing, the impact of our young people not being in school, and the fact that 65% of our young people they were worried about their mental health, and 16% of our young people have been entirely isolated since the start of the lockdown. When we did the survey, we had a large number of mental health challenges, but for the speed of time, fear and promoting resilience and encouragement has to be key if we are going to sort that out. Now, going forward, as a city, what we needed to look at and what we are looking at is post-COVID recovery. We must be a greener city for all, which is across the country, but it must also be fairer and more inclusive, because in part, if you live in parts of Birmingham, you can leave the city centre and go less than 3 miles away, and your life expectancy is between 5 to 8 years shorter than other parts of the city, just because of where you live and you grow up. And we need to implement innovation approaches to return our services so that they can recognise and respond to identified root causes of deprivation, poverty and inequality. We have to mean this. Words are cheap. And, you know, I've loved what Alice has said, because the lessons from COVID, if they are not learned now, and if we do not go forward with those lessons, this is going to happen again. A pandemic will happen again. And if we are not in a position to actually deal with it the next time round, we cannot then be excused. And my last point is inclusion has to be key to everything we do. I am tired of hearing that we have hard to reach communities. No, they're not hard to reach. I'm a Black woman. I'm not hard to reach. You have to make an effort to reach me. Otherwise, I am not always aware of how to access things that people have put out there. So we have to learn to change the way we engage with our communities. And that actually includes some of our working class communities that for 3-4 generations, they've not worked. They've absolutely and utterly stepped out of the race. I'm going to end by saying, COVID has been a sad time for me, but it's also been an opportunity. It's an opportunity to see change. And I'll stop there. Thank you.
Thanks, Councillor Hamilton. And that there was a rallying call to wrap up all the input from the speakers. So thank you very much for that. So if I can invite the panelists back so that we can have some conversation based on the lots of questions that have come in. So I'm going to start with a question really that draws together a little bit of a theme about, we talk about COVID fatigue, but I'm picking up amongst the questions, a bit amongst us as the public health community, a bit of health inequalities fatigue. So that desire to see things change more quickly, more visibly, you know, why are we not seeing changes, and potentially also in terms of health inequalities around race. So if we can have your reflections on that, should we start, Kevin, with yourself?
Thanks, Janelle, and can I just say thanks everybody. That's an amazing panel. I think we need to challenge that assumption and that narrative, you know, Janelle, because what I've seen, and I hope what I've shown in the work that we're doing with London, is that we have grasped this opportunity to make the change that we have been calling for so long. And I've been in public health practice now for 25 years, and I have never seen a moment in time where every partner, every community, every member of our city is actually focused on these inequalities, the unfairness, and a commitment to do things differently. So that's the first thing, just in terms of let's not be in a mindset of defeatism now. Second, let's acknowledge the gains that we have made even in the course of the pandemic in the last year. There's a question in the chat about, well, what has been achieved? You know, we now have better data than we did at the beginning of the pandemic. We now have campaigns which have people that look like me, focused on people like me in different languages, engaging communities. And we're investing in and ensuring that all of our programs are far more culturally competent than they have been. And that is happening in the NHS. It has always happened in local government, and it's going on now. So I want to challenge that assumption, because I think we need to get our mind in the frame that we have to build on the gains, because the work that's putting up ahead is going to be even more challenging, and we need to do that mobilization, and it starts with us.
Thanks, Kevin. Good challenge back. Would anyone else like to pick pick it up and perhaps even reflect on the question about, so if not health inequalities fatigue, are we just then talking to ourselves? Are we in a particular bubble around our partnerships? So I think perhaps, Joe, if we pass it on to yourself, are we just talking to ourselves? That's what your report seemed to suggest.
So it's the report,
not your report,
college,
but the report, sorry, that you were talking to. Yeah,
I think I suppose listening to the presentations, I mean, you know, that polling data is the polling data, it's attitudes that have been collected by the public, and we need to reflect on them. I think what I've really been struck by listening to the presentations is this real opportunity around local leadership, you know, and maybe there is something about the fact that where this becomes real for people is in their communities, and the role that colleagues around this, you know, table have been talking about in terms of that local leadership. That seems to me the real opportunity here. And perhaps that's where, if you can start to get that shift in understanding about what can be done, you know, maybe that eventually does start to change some of the more sort of national dialogue. But I think there are huge opportunities because of the way local leaders have responded, and it's about building on those.
Councillor Hamilton, would you agree with that? Huge opportunities for local leaders and leadership here?
Absolutely. For myself, over the last year, the data that, well, the two things. One, I believe public health has absolutely earned their place in local government. And if anybody tries to challenge that, that is going to be my first issue. Secondly, I do believe that local leadership is the way, well, it has always been the way forward. We know our communities, and with the expertise of public health and with the knowledge of people like myself as local councillors, it can't be beaten. And also working with the NHS, primary care, the voluntary sector, it cannot just be one place or another, it has to be joined up. But I know that over the last year, I've never seen things shift where data would be an issue, where things around protection, data protection or whatever, all that seemed to leave the room during the pandemic. And I'm just hoping, and I agree with Kevin, that we build on some of this excellent work that's been done around the country to ensure that our citizens start to see the value of it, because they can't go on like this. The level of fear, the level of distrust, they feel that people don't care. They need to start to feel that we're listening to them. And I'll stop there.
Thanks. So Alison, Jim, Councillor Hamilton, resounding support for the Directors of Public Health and Leadership. Where do you want to come in on some of those questions that have been put to us?
Alice, after you.
Okay, so I mean, I'm just reflecting, I mean, that was great from Councillor Hamilton, because actually that's how I feel in my local place in Gateshead as well, that, you know, if people had asked a year ago what your job was, how much time do you spend explaining to them what public health was? Whereas I feel like we're a year later, we don't need to do that. And I think the CMO talked about that this morning as well. He talked about the fact that he's improved all of his relationships across government. So we really have an opportunity to you know, think about actually how we do use this moment to influence in the right way. I have to say that I've recognised people feeling frustrated and impatient, because I'm the most impatient person in the entire world. My mum would definitely agree with that. But I think that we can't do these jobs unless we do tackle inequalities. And we can't just tackle inequalities from the perspective of the lifestyle issues that everybody kind of relates back to us. We have to start having these conversations, and that's why public health is in local government. So, you know, as much as I recognise other people's frustrations, I equally think that it's something we must do. And then picking up on Councillor Hamilton's point there at the end is actually, I think the community leadership has developed and changed over the last 12 months. And I think it's about how we as local directors of public health or public health teams across the country actually form better relationships with our communities, so that we can hand over the power to those communities to define what it is that's needed for them, and to actually give people in those communities a voice. Because the reason things haven't changed is because the people who are most disadvantaged are less likely to vote. What we need to do is make sure that people feel that they are engaged. Well, we don't need to make sure that people are engaged, because that's not, but we need to enable a context where people feel engaged and feel that they have a voice and feel that they have a place, so that then they start to vote, and then we start to see a shift and change in the way that people are listening to them. So there is a whole piece of work that we need to do, and some of it is about handing over power, and some of it is just about, you know, tenacity or stubbornness, whichever you'd like to look at it as.
Right, thanks, Alice. Jim.
I think we're at a time of both the greatest opportunity and the greatest risk for the public health profession in the last 15 years. The greatest opportunity is we've come out of COVID making it very clear that national government can't do without us, can't deliver. And also our NHS partners, hugely valuable though they are, can't deliver. We all need each other. None of us are perfect. I think the other thing is we've demonstrated that in local government we have delivered more in 6 years than we did in the NHS in the previous 20 in many respects. NHS needs public health, but local government health is a different animal. So the great risk, the great opportunity here is to realise that change making takes decades, unless there's an immovable force that makes it happen in weeks, i.e. the pandemic. So we're in this for the long haul. The greater opportunity for us is to articulate health inequalities and how we work together with local communities and local agents to do that. So put the NHS and central government and all the other agencies alongside us as valued partners. The great risk is that if we just go back to a language that sounds rather academic and distant, and we don't take up the great challenge that the Frameworks Institute working with Joe has given us. That's a leadership challenge. And it's a leadership challenge that we can only rise to with local elected members. It also requires a great deal of humility. So our NHS colleagues need to understand and discern their priorities. Directors of public health understand and discern ours, elected members, because we've all got a role to play. But it's culture, behaviour and long-term thinking, not the short-term policy objectives of spending reviews that will get us out of this.
Thanks, Jim. So you've taken us on to another area that's come through in the questions, which is around how we work together with our partners. And I know, Kevin, you talked quite a bit about system partners. Now, clearly, the NHS is a major system partner. We've got NHS reorganisation happening at the same time. So there are two questions, if you can reflect on, I'll take them together. How can we make the next 4 years about healthier, fairer places and not about whether the NHS has enough money? And then the second one, I suppose, is that challenge back, which Chris Whitty picked up about, you know, that the urgent crowds out the important, but long term. And I suppose my challenge is both in local government and NHS. Often the urgent gets funded, and the long-term prevention and public health work struggles in terms of funding, both in both organisations, let's say. So those two challenges, you know, it isn't about the money, but it is about the money. How do we provide leadership within that those shifting movements over the next year? Kevin, let's start with you.
Thanks, Janelle. So on the first reflection on system partners, let me be absolutely clear here that if the pandemic has taught us anything, is that I view the public, faith communities, community organizations, businesses, head teachers as system partners. I would like us not to habitually go back to the NHS as, and I know that's not what we're doing, but I just want to be absolutely clear here to Alice's point about the lessons that the pandemic have taught us and how we therefore change our behaviors moving forward. So that more expansive view of who system partners are, valuing those relationships, investing in those relationships, creating governance that are meaningful to sustain those relationships, I think will be key. And with the governance, as we're doing here in London with the Grand Challenge and our missions, co-creating, co-producing with those system partners, the strategies that are required to get our city moving again as we emerge from lockdown. Third, I can't underscore this enough, data. Data, what gets measured, what gets done, what we understand that we're able to improve. And we cannot emerge from this with a dearth of data that will continue to hold us back. So again, I think that's really important on the systems partnership. And then finally, to your question on the urgent and important versus the strategic and sustainable, I think that is a challenge that we're going to continue to have. We cannot build back better thinking of a 6-week or a 3-month timeline, because the inequalities that we've exacerbated have been ingrained within societies for decades. So I think taking that long-term strategic planning priority, working across system partners, but understanding what are our short-term milestones that we need to be working towards. So whether it is preschool meals for every kid in the school, every child in the city, no-brainers that we should be focused on and accelerating in the short term to create the momentum, the engagement, and the will to go for the medium and long term. That's, I think, one of the ways in which we balance that short and medium term.
Thanks, Kevin. Who would like to, who in the panel would like to pick up next? Let me go to Councillor Hamilton. Yes. So can we in local government balance that short term, long term, and how do we work with our NHS partners, communities, and others? How do we make the money go around?
For me, as a local councillor, and I'll just say it straight, there's no other game in town. The money, there just isn't enough of it. So we have to learn to work in a more smarter way. So when you're working with the system, you need to look, I believe if you're going to make change, you need to look at people in the place where they live. Because I've said before, I was born in Birmingham, I've grown up in Birmingham, I went to university in Birmingham, I've had my children in Birmingham, and I will become an old age pensioner in Birmingham. I don't know if I'll be a pleasant one, but I will do. But I expect people to come to me in the place where I am, and we work together to make the changes in what I need to grow old gracefully. And I'm saying that sparingly. But for me, the system is key. You have got to understand the data. You've got to understand the population you're dealing with. You're going to have to understand the changes you need to make. You're going to have to understand who needs to lead on it. And sometimes the problem we've had in the past, the NHS or local government or whoever wants to lead on everything when they perhaps are not the right people. So it's how are we going to work with our local universities? I've heard Kevin talk about teachers and others, but going forward, thinking out of the box, because change is possible and public health is key to this, but part of it is relinquishing some of their power, allowing others to take hold of that power. The NHS the same way, local government the same way, and putting the person first. And I'll stop there.
Thanks, Councillor Hamilton. And you really, I don't know whether you heard Professor Whitty this morning, but he was strong on people who live in a community, grow up in a community, are there the whole time and are totally invested in a community. And the connection he was making was also to research. And so there's data for the immediate, but it's that research data for the longer term. And he was making that call for local government to get involved in making sure that we do capture and research in our local communities and really harness, what you've been talking about in terms of your commitment to a place and through a lifetime. So let me go to Joe. Would you like to come in, and then I'll finish it again with Jim and then Alice.
Yeah, great. I think one thing I was just reflecting on from the sort of earlier discussion about the health inequalities fatigue. There's something about you know, the language that we use and health inequalities is a sort of abstract concept, you know, it's a population effect, it's not an individual effect. And so, you know, when we're talking about health inequalities, that doesn't necessarily mean something to the individuals we're communicating with. So I think that language thing is really important. But on the kind of incentives to think more long term, which has to be absolutely at the heart of getting the change we want. I mean, one of the things we've been talking about at the Health Foundation is the Ons Health Index, which was published as a beta form before Christmas. There was a consultation exercise, which has now closed, but it's going to be revised and launched later in the year. And the Health Index came out of Sally Davis's CMO report in 2018, when she was sort of advocating for the need to have an alternative measure to GDP, something where we can look at the sort of health stock of the country. Now, you know, I know all the reasons why the health index isn't perfect, but I think one of the things that's interesting in it is that it does include measures that are both showing sort of immediate health effects, so, you know, health status of individuals, but it also has in measures that reflect some of the sort of things we need to build into society that have a more long-term effect. So, you know, more green access to green space, or taking children out of poverty. And I think there's something really interesting about the fact that the index does start to incentivize potentially and kind of measure some of the action that if you take it now, it may not deliver benefit for several years to come, but in a sense, you can demonstrate through the index that you're making that investment. So I think there is something that we should engage in around that and think about. And then the final thing, I think there's something about the fact of, you know, if we could perhaps be better at tracking what is the government investment in the strategies that we know keep people well, and kind of show what that looks like relative to the investments that government makes that actually is about not just poor health, but sort of wider societal consequences of poor health, whether it's mental health or other factors. And I think this, you know, if we could better track that sort of what is the investment being made nationally in that kind of preventative action, it would give us something a bit more tangible, because I think, you know, we intuitively we know that should at least stay the same, if not go up year on year. And if it isn't, it gives something more direct to point at.
Thanks, Joe. That's really, really helpful. And that theme about data and understanding and knowing exactly what's going on, and how we are making that impact. So Alice, if I can come to you, and then Jim.
Yeah, thank you, Janelle. Yeah, so I mean, I'm reflecting on all of the things that the previous speakers have said, and actually, you know, agree with everything that's been said. But what I'm thinking in terms of adding to that is, it's not just about the data in terms of the numbers, it's about the qualitative data that we get when, you know, so it's, and I think lots of people on the panel have already spoken about the importance of relationships and how we build relationships with our communities. And, you know, so there is something about permission to go out and build relationships with real people in real spaces. I think probably over a number of years, we've got really caught up in commissioning a service and the tangible things that you can see when you've written a service spec and you've commissioned something for however many thousands of pounds. And actually, sometimes it's just the conversations that you have at the local level that make it, you know, all the difference. So for me, there is something about actually going back to basics and enabling, giving permission for people to get into their spaces and to understand exactly how it is and what communities themselves think the solutions are. And actually, many of the solutions that the communities that I've been involved with come up with are not expensive. They're not big things. You know, we worked with a community in Gateshead around childhood obesity, and they talked about safer streets to be able to walk their kids to school, you know, looking at parking around the school. You know, there's kind of basic stuff that we would never have thought about if we'd flown into that area and thought we could land a well-intentioned service. So I love the research plug that Chris made this morning, and I would just make the plug slightly further that it needs to not just be the kind of the research that we're used to in terms of the gold standard RCTs, but let's really start to embrace qualitative research and the understanding that gives us around the people that we all are here to serve.
Great, thanks, Alice, and challenging the methodology of that research, isn't it? And that, you know, even contributing to how we can do research in a meaningful way in our communities. Yeah, Jim.
I'd agree with everything that's been said. I think at the end of the day, this remains a cultural issue. You know, the most important thing we can do to make our really precious NHS sustainable for the future is for every single agency and actor to realise that we all have a role, and for every single agency and actor to respect that role. Because you could say the same about housing, which is equally crucial for health. In fact, is foundational for health, and the same about education. So, and I've pasted in the chat my link to the Team of Teams book. Awful cover, great book. I think the second thing is where that fits into the research agenda is an opportunity for us really to recover models of research that sit well with health inequalities, because they start from a position of respecting and understanding the individual and the community. So not doing research to people, doing research with people and working with people. And there's one little blue book, which I've forgotten the name of, but it was published by the Health Foundation, where they used a multiple set of disciplines to look at childhood obesity. So they had a sociologist, a lawyer, a psychologist, and various others look at it. And I think what that says to me is that actually we spent too long in public health research trying to be biomedical research, and actually we need to be much more research about and with people for change. And it's an ethical disposition and it's an ethical commitment that follows from that culture. We have the opportunity to do this reset, but only if we all put our minds and efforts to it and seize the money from the funders. It's great that local government's been recognised for research. That's really good, but we have a lot of work to do to build the infrastructure to make it capable to do that. And let's do it as we want to do. Let's not ape biomedical research, because that needs to do what it does and we need to do what we do.
Thanks, Jim. So if I could draw to a close there, panel, I think we've had a fantastic input in terms of your presentations, but equally just the conversation, the Q&As, just really impressive. So much coming, so much thought, energy, knowledge, and thinking about what's needed over this next year is really, really inspiring. I know that Paul Ogden has also put on the chat, if you can see it, the Public Health Annual Report 2021, Rising to the Challenges of COVID, which looks at what we have helped to achieve and what could be done better during COVID-19. So I do commend that report to you. So I think it builds on a lot of what we've been talking about here and gives those real local examples of work that's been done. I do hope you found it helpful. The presentations will be available on the LGA's events page within 2 days. Or I think I heard this morning's session is already potentially up or will be later today. So a very impressive turnaround by the LGA team. There'll be a short survey that we are going to send to you. Please do complete it. You'll appreciate this is an unusual way of doing a conference, so we would value your feedback. I think that would be really helpful in terms of the way in which we do conferences. And finally, if you commend tomorrow's speakers and program to you, really hope that you can join us. The details are on the LGA website, and your booking for today allows you access for tomorrow as well. So it's been fantastic to spend the afternoon with you. Thanks again to speakers, and thank you all, and please stay safe. Bye for now.